Started.
So good afternoon, everyone, and thank you so much for joining us. Happy New Year. Welcome to today's webinar entitled Substance Use Disorder Treatment 101 that we're hosting as part of SAMHSA's SUD Treatment Month. We are so honored to have you join us for this really important event. SAMHSA launched Substance Use Disorder Treatment Month, or Treatment Month as we're calling it, on January 1st as a new observance. And so we are really excited about that, to have this new observance. It's one dedicated to supporting individuals contemplating or seeking help for their substance use, practitioners who are treating or considering treating substance use disorders, friends, families, and loved ones of those affected. Through this initiative, SAMHSA seeks to raise awareness about SUD treatment options, including medications for opioid use disorder and substance use disorder, reduce stigma surrounding treatment, encourage those on their recovery journeys, and promote best practices in screening, intervention, and SUD treatment among healthcare providers. Recent data from our National Survey on Drug Use and Health demonstrates that substance use disorders profoundly impact millions of people, their families, and communities across the United States, and affecting all demographics and all walks of life. The overdose crisis in the United States has caused a loss of hundreds and thousands of lives. And we know these are our friends, these are our family members, our neighbors, and our coworkers. Despite these challenges, we also know that millions of Americans are living in recovery with good health and purpose in their lives. A key factor contributing to that recovery is access to compassionate and evidence-based treatment and support systems. We know that implementing effective strategies for treatment and recovery, it takes all of us coming together as a community of practitioners, policymakers, advocates, and supporters. We are so pleased at SAMHSA to be able to work with all of our partners and to lead public health efforts that advance mental health, prevent substance misuse, and provide treatment and supports that foster recovery. SAMHSA envisions a world where individuals affected by or at risk for mental health or substance use conditions are able to receive equitable, high-quality care, achieve well-being, and ultimately thrive in their lives. Today's session is designed to provide foundational knowledge about substance use disorders, what they are, their risk factors, and how they develop. The speakers will also lay a foundation for why treatment, including medications and other services, are effective and important. We're so privileged to have an outstanding lineup of speakers today, each of whom will bring a wealth of expertise and experience. They'll share practical knowledge and resources that you can use in your profession, within your organizations, and your communities. And so before I begin, I want to extend just a heartfelt thank you to each of you for your commitment to addressing substance use disorders. Whether you're a clinician or whether you're a policymaker, a peer supporter, or someone simply eager to learn and to be able to help individuals within your lives, your dedication to this critical cause makes a significant difference for people, families, and communities all across the country. So thank you so much for your dedication and commitment. Thank you for being here with us today. And with that, we're going to go ahead and get started. I'll turn the floor over now to Dr. Ingvild Olsen. And Dr. Olsen is our director of the Center for Substance Use Treatment.
Great. Thank you so much, Dr. Delphine Rittman, and good afternoon, everyone. It really is my pleasure to be with you here for this webinar during this first ever Substance Use Disorder Treatment Month. As Dr. Delphine Rittman mentioned, to provide really a foundational overview of substance use disorders, or what we call SUDs. Now, before we delve into what SUDs are, I want to take a moment to really talk about why we're focusing on these health conditions. So what is so special about SUDs that we need to have a month dedicated to their treatment? Well, one reason is because SUDs have enormous individual, family, community, and societal impacts that really have only grown over the last several decades. So everyone has probably heard of the opioid epidemic. That has been hard to ignore when nearly 750,000 people have died from overdose since 1999, with deaths particularly skyrocketing during the COVID pandemic And when extremely potent, illicitly made fentanyl started replacing heroin and prescription opioids in many areas of the country. All of those lives lost, those people who were our neighbors, our friends, our family members, our loved ones, our coworkers, they are represented in the brown line towards the top of this graph in the upper left-hand corner, as you see on the slide. And while it is very encouraging that the line is curving downwards, the number of people dying remains way too high. And unfortunately, not all communities or populations in the US are experiencing reductions in these numbers. But while opioids have gotten a lot of attention, many people may be surprised to learn that alcohol contributes to an even higher number of deaths per year. In fact, more than 178,000 people died from alcohol-related causes from 2020 to 2021, according to the CDC. And tobacco continues to be the leading cause of preventable death in the US, killing more than 480,000 Americans every year. Now, substance use and SUDs also don't just lead to loss of life. There are a host of other health-related conditions caused or worsened by SUDs as well. And many of these are described in the very small print in the graphics in the bottom left of the slide. And so I'll just note a few of them, that this includes medical conditions such as liver disease, a range of different cancers, pancreatitis, heart problems, gastrointestinal bleeding, infections and infectious diseases, obstructive lung disease, neurological and endocrine problems. There are also worsening mental health conditions such as depression, anxiety, and suicide. And other issues that are not seen here include driving, boating, and workplace accidents, falls, job loss, homelessness, and interpersonal violence and incarceration. And all of that translates into a tremendous cost to society. In fact, studies estimate that SUDs cost the US upwards of $800 billion to over $1 trillion per year in lost productivity, healthcare and social services, criminal justice resources, and premature mortality. Now, for a long time, many people thought that SUDs only happened to other people. They said it couldn't happen to me or my family. But these conditions are common, as data from SAMHSA's National Survey on Drug Use and Health shows. We're talking about almost 50 million people ages 12 or older with either alcohol use disorder, a drug use disorder, or both. And we sometimes forget to include nicotine or tobacco use disorder among substance use disorders. And although it is unfortunate that it has taken an overdose crisis to reach this point, it is clear that Americans are increasingly becoming aware of SUDs. The Pew Research Institute in 2017, in fact, found that almost half of all American adults surveyed said that they had a family member or close friend with an addiction, either past or present. Now, unfortunately, this elevated awareness of the pervasiveness of SUDs has not been accompanied by a universal awareness or adoption of non-judgmental, scientifically based, factual information about what SUDs and addiction are and how they can be effectively prevented and treated. So we know that SUDs are among the most stigmatized health conditions, not just in this country, but around the world. So people with SUDs are told it's their fault that they can't stop drinking or using drugs, and that they somehow deserve all the negative things that happen to them. Some of the disparaging language used to describe people with SUDs, such as calling people junkies or addicts, perpetuates that stigma. And discriminatory practices and policies that limit access to supportive social services and even some medical care for people with SUDs further sends the message that they are not deserving of support. So as a result, people with SUDs are less likely to seek treatment or drop out of care when they do seek it. Research has documented that stigma is one reason many healthcare providers don't want to provide SUD treatment, even though they could. And patients with SUDs are often negatively viewed, blamed for their conditions, and treated poorly in healthcare settings, even in specialty SUD treatment programs, by healthcare professionals who purportedly are there to help, not tear people down. So it's no surprise that people with an SUD who expect or experience stigma have poor health outcomes. Now, the fact is that a substance use disorder or addiction is not a moral failing or lack of willpower. It's not a character flaw. It's not a disease of morality. Advances in the scientific understanding of this definition and this condition have definitively debunked these ideas. So then, what are they? What are substance use disorders? And I've been mentioning SUDs and addiction, and is there a difference? Well, since 2013, the US has been using the definition of substance use disorder as described in the chapter on substance-related and addictive disorders in the Diagnostic and Statistical Manual of Mental Disorders from the American Psychiatric Association, now in its 5th edition, which was recently revised a couple years ago. In essence, SUDs refers to a group of diagnoses identified by the specific substance involved. So for example, opioid use disorder, alcohol use disorder, and so on. They all have common predisposing factors, similar defining signs and symptoms, and shared brain regions that are involved in their development. SUDs are characterized across a spectrum of mild, moderate, or severe, depending on how many diagnostic criteria a person meets. The stage of severity can change over time, with milder forms becoming more severe, but also more severe forms responding to treatment and recovery supports and lessening in severity. Remission from an SUD is a state of wellness when no signs or symptoms, with the exception of craving, have been present for at least 3 to 12 months and sometimes longer. Now, because most SUDs are defined by 11 diagnostic criteria, which is a lot, another easier way of thinking about an SUD is that it is a disorder involving compulsive, uncontrolled use of a substance despite negative consequences. And to give you an example, here I've outlined the diagnostic criteria for an opioid use disorder. Now, on the left hand of the slide, there are criteria that describe that compulsive, uncontrolled use of opioids. And when you hear people with an OUD talk about their severe addiction, you'll hear them say that they often used more than they intended, had these unrelenting cravings and unremitting thoughts about using, and spent a large part of their day, their attention and focus on getting, using, and or recovering from their opiate use. Now, at its most extreme, really their entire life becomes wrapped up in and revolves around the use of opioids. On the other hand, side of the slide, rather, are the criteria that speak to the negative consequences associated with the compulsive and continued opioid use. Now, that can include physical problems such as wounds, bacterial infections, hepatitis C or HIV, or mental health problems like depression. People with severe OUD also may continue using despite losing their job, their home, or relationships with loved ones. Now, for many people with untreated OUD, continued use happens even after a non-fatal overdose. Now, I show you all this to illustrate the diagnostic criteria that are common to all SUDs, but also really because they focused on OUD, it is often very misunderstood. And that is because the two criteria at the bottom left of this slide, so tolerance and withdrawal, are often mistaken as the only defining symptoms of opioid use disorder or opioid addiction. And as you can see here at the bottom, it says tolerance and withdrawal alone do not imply a disorder or disease. And let me explain that a little bit further. So tolerance refers to how the body adapts to a substance or medication, like alcohol or opioids or other medications sometimes taken for blood pressure, or even steroid medications taken sometimes for really severe musculoskeletal problems like rheumatoid arthritis. And so in those situations, increasing amounts may be needed to have the same effects. Now, for opioids, That means that people's bodies become accustomed to many of the effects of the opioids they may be taking. So whether that be pain relief in someone with cancer, sleepiness, or effects on breathing. Withdrawal is a series of symptoms experienced by people who have been using substances or taking medications, including, for example, opioids, for a while, and then they quickly either cut back or stop abruptly. The withdrawal symptoms from opioids makes people feel like they have a really bad case of the flu, and occurs because the brain, skin, eyes, nose, bones, and intestinal tract, which have become used to the presence of the opioids, now respond to their absence. And while tolerance and withdrawal, often together referred to as physical dependence, are features of opioid use disorders, they cannot be used by themselves to define that OUD, as you saw in the previous slide. And that really becomes important when we're talking about treatments such as methadone and buprenorphine, since these can also cause physical dependence. However, for an opioid use disorder or opioid addiction to be present, there has to be those compulsive, uncontrolled use of opioids despite the negative consequences. So those other pieces of the diagnostic criteria. And many, many people who take methadone or buprenorphine as treatment for OUD do not have those symptoms, and so then would be considered to be in remission and further really in recovery. But more on that in our second webinar that we're hosting for SUD Treatment Month on January 30th. Now, I mentioned that, what is the difference between a substance use disorder and addiction? And I've been kind of using those maybe seemingly somewhat interchangeably, but there is a lot of confusion about those. And they're not exactly the same, even though there is significant overlap. The one way to think about the difference is outlined in this slide. Addiction is a disease, but not a separate diagnosis. There really is currently no way for us to measure addiction, but it can be a word that captures the complexity of what is happening in the brain of a person with the disease. And most specialists and researchers consider addiction to represent and align with a moderate to severe SUD. Now, SUDs are the diagnoses a healthcare practitioner makes, made up of the signs and symptoms of the disease and the criteria that I've described for you. It's also a way to really describe the spectrum of severity within and across different SUDs, and a system for measuring response to treatment over time. Now, I keep talking about kind of these complex happenings in the brain of someone with a substance use disorder or an addiction. So what are those? Well, before we kind of get into that, in order to really best understand it, it's important to understand something about the functioning of the brain when SUD or addiction is not present. So this image shows the three key parts of the brain that are involved in the development of addiction. And I'm just going to walk you through this, starting at the top right with the basal ganglia in blue. So this is an area that is located deep in the evolutionarily oldest part of the human brain, and is a core part of the brain's reward circuit. So that is that this is the part of the brain that responds to natural rewards, such as eating good food, having sex, and spending time with friends and loved ones. Brain activity here makes us feel good and teaches us to continue pursuing those activities that generate those positive feelings, even without being consciously aware that we're doing so. This is really what perpetuates our species as human beings. So the basal ganglia is also involved in keeping our body movement smooth and coordinated. The next area is the extended amygdala in red, just below the basal ganglia. Another evolutionarily old brain region, this area is involved in the body's stress response. So this is the area that generates feelings of anxiety, fear, unease, and other negative emotions, especially in response to external environments, like someone chasing you down the street, or, being in a really uncomfortable spot where you're being put on the spot, and are really anxious and nervous about it. When someone is really kind of threatening you, it's that fight or flight response that some people may have heard about. And the brain activity here also happens automatically without a whole lot of conscious awareness. Now, the third area is the prefrontal cortex in green, really here at the front of the brain. This is the evolutionarily youngest part of the human brain and is the area critical for decision-making, managing and organizing time and tasks, impulse control, and conscious awareness and attention. It steers all of our executive functioning, and that may be a familiar term for folks. Now, I should note that the prefrontal cortex does not fully mature until people are about age 26. So that's why teenagers, my own included, can be very impulsive and do really risky things like drive down the wrong way on a one-way street as a shortcut to try and get to a friend without really thinking about the consequences. So that impulsivity can also lead to early substance use, which then in turn can impact and further delay the maturation of the prefrontal cortex. Now, the other aspect of brain function that is important to understand as we talk about SUDs and addiction is the communication systems between different regions and areas of the brain. So much like humans use words to transmit specific messages that are then picked up by the ears and eyes of other humans, processed, understood, and responded to, the cells of the human brain, called neurons, communicate using chemical messengers called neurotransmitters that connect to specific receptors on other neurons in the brain. These receiving neurons then process and translate the received message into a response. Different neurotransmitters connecting with different neurons will generate different responses. And the cartoons on this slide show how that can happen. So here it really is about dopamine and dopamine kind of going into being released, going into this area called the synapse, and then attaching to receptors and generating a response in the neighboring neuron. Now, there are hundreds of different neurotransmitters, but for all substance use disorders and addiction, the common one that many may have heard about is exactly that, dopamine. This is a key reward-related neurotransmitter that is affected by all substances that have addictive potential. Now, the communication systems that neurotransmitters and other similar chemical messengers throughout the body help maintain are really critical to having all the different brain and body functions happen automatically and seamlessly. So we don't really even have to think about them so much. That is a state of what is known as homeostasis, or kind of this balance. And when homeostasis comes out of balance, then that causes other types of responses. Now, dopamine, for example, is one of the neurotransmitters that makes connections with both the basal ganglia and the prefrontal cortex. And there are other neurotransmitters that connect the extended amygdala also to the prefrontal cortex and to the basal ganglia. So all three of those parts of the brain are connected. And dopamine helps our brains pay attention to, learn from, and continue to pursue those things that make us feel good. While at the same time, our prefrontal cortex also balances risks and potential harms from those behaviors and putting a brake on engaging in them. Now, because our bodies really don't like, as I said, that imbalance or instability, neurons and other cells in the body will make all sorts of adaptations to try to maintain that balance, even if those adaptations have downsides, as we're going to see in a minute. But before we get to what happens in these different brain regions in addiction, I did want to say a word about risk factors of addiction and SUDs. And while it is true that anyone can develop a substance use disorder, it is also true that not everyone who uses a substance, whether that be tobacco, alcohol, heroin, cocaine, fentanyl, or oxycodone, develops a substance use disorder or addiction. Now, in fact, only about 20% of the people in SAMHSA's National Survey on Drug Use and Health data who reported using a substance in the past year were identified as meeting criteria for a substance use disorder. So how do we really explain that? One of the reasons lies in the known risk factors for substance use disorder that are shown on the slide. There may be many that we also still don't really totally understand, as the research into exactly the brain mechanisms and all of the different pieces that play into this complex interplay, that research is still ongoing. But we do know that the risk factors that we are aware of represent the unique biological, environmental, and substance-related factors that interact in complex ways to impact specific brain mechanisms in any given individual to cause an addiction. So for example, we know that between 40 to 60% of the risk of developing a substance use disorder is genetically based. So there's a lot of research happening in this area, because we still have a lot left to learn about exactly which genes, which combination of genes predict risk of which substance use disorders. Or maybe there's a set that predicts just addiction in general. Now, we do know that there are some genes that predict risk of substance use disorder, and these have to do with how different people or different populations of people respond to different types of substances or medications. So East Asian populations, for example, generally have a lower risk of alcohol use disorder because of a common genetic variant involved in the liver metabolism of alcohol that causes flushing and some discomfort. And so their risk is actually lower because of that genetic variant. Now, we also know that gender plays a role, as does the presence of mental health disorders such as depression and anxiety-related conditions. Exactly why that is not entirely totally yet clear, but as we'll see, that some of the there's an interplay between substance use and mental health conditions. A large body of research also has found that adverse childhood experiences, or something called ACEs, such as early childhood physical, emotional, or sexual abuse, domestic violence, witnessing violence in general, poverty, or loss of a parent, can really increase the risk of developing a substance use disorder or addiction by upwards of 10-fold. And so the higher the number of ACEs, the higher the risk. Now, early onset of use, especially before age 14, is also associated with a higher risk of developing an SUD or addiction. And the risk of early onset of use is also associated with higher number of ACEs and the presence of depression in childhood. So you can see there's a lot of complex interaction between these risk factors, and we'll see why in a minute. We also know that a higher availability of substances, peer pressure, permissive attitudes about substance use, especially in adolescence, also are environmental risk factors. And then finally, there are some features of the substances themselves that pose risk. For example, very potent substances like fentanyl that get to the brain really quickly through smoking or injecting, and that last for a relatively short period of time, like heroin or cocaine, have more addictive potential than substances that are taken by mouth, have to get absorbed into the bloodstream, and maybe pass through the liver, and then they last for several hours. So that the relative addictive potential of those substances or medications is much less. But whatever the risk factors that may be present, what happens in addiction is essentially a reward system gone awry, with an imbalance between the basal ganglia that we talked about before, the extended amygdala that also sits very close here, that stress response, and the prefrontal cortex, that executive functioning piece of our brains, even though the brain's attempts at avoiding that imbalance and correcting that imbalance comes into play. So we're going to walk through what happens, but to help illustrate, I've asked my colleague and friend, David Abadallah, a public health advisor in SAMHSA's Office of Recovery, to join me. And I am so unbelievably thankful, David, for you being willing to talk through this with me and really, I think, highlight exactly how this happens, but also that people are so much more than this. I think that's the other message that we really want to convey. Because you are someone with lived experience of a substance use disorder. and you've been in recovery for many, many, many years. I'm wondering if you can actually reflect back on, when your substance use first started, and talk a little bit about kind of how you felt at that time. What was that experience like?
Yeah, thanks for having me, Dr. Olson. And you can hear me, right? Good sound? Great.
Yeah.
Yes, so it's an honor and a privilege to be here today with you and share a little bit about my lived experience and how it relates to my professional role now. So as Dr. Olson mentioned, I am a person in recovery. I'm also formerly incarcerated. And if you're wondering how a formerly incarcerated person came to be working for the federal government, that's a whole another webinar for another time. But to get back to your question, Dr. Olson, I am in recovery from both substance use and mental health conditions. And while I am in recovery from multiple substance use disorders, I had the majority of my consequences associated with one, and that was opioids. And that is what led me down to a path of incarceration, in and out of treatment programs, in and out of jail, drug court, probation, parole, the entire criminal justice system. And so, I can think back to the first time that I ingested an opioid legally, and I had actually gotten my wisdom teeth out, and I want to say I was 16 or 17 at the time. And during the previous few years, I had experimented with other substances and maybe had a mild or moderate alcohol use disorder, or I was using marijuana quite frequently, but I didn't have that many consequences. And I don't know if I had never been introduced to opioids, if I would have stopped and just grown out of that. But I can tell you that the first time I took an opioid, my body's reaction to it was different. And I remember I was talking to my mom because she had received a prescription for hydrocodone, a couple of years into my recovery. And she said, David, I don't understand what you find pleasurable about this. I feel drowsy. I feel out of control. I feel nauseous. And then to further accentuate that example, actually 2 days ago, my wife just had surgery. And so she's being prescribed a pretty heavy narcotic to deal with the pain. And then same thing with her. But my body reacted in a completely different way. And I remember when I took the hydrocodone after I got my wisdom teeth out, I remember sitting on my bed and I remember thinking, this is what I want to feel like the rest of my life. And this is legal. And the doctor that prescribed them to me didn't say anything about tolerance or withdrawal or addiction. And the lights just turned off in the room that I'm in. So let me stand up and wait, that was a little miscue. 1 second. They're back on. Okay. So I remember taking that tablet and, for the next couple of hours, I felt the anxiety that I had every day lift away. I felt my depression go away. I felt energized. I felt like I wanted to talk to people. And in many ways, that's a peculiar reaction, because if you think about it, opioids are central nervous system depressants. And so genetically, what is happening at that molecular and cellular level to cause a person to have these feelings that are in many ways opposite of what you would think would be associated with it. And although, I didn't develop an addiction right away after I got that first prescription, it wasn't long before I started receiving prescriptions regularly. And then first the physical dependence started, and the tolerance, the withdrawal, and then those DSM criteria that you mentioned, the mild, moderate to severe, I started checking those off one by one by one.
Yeah. So that first piece that you were mentioning about how kind of it made your anxiety go away, right? The depression get better, kind of that response that you had, right? I mean, that really correlates to that kind of spike in dopamine, right? That happens kind of in the basal ganglia, that feeling of pleasure or ease, actually, because you may have been one of those people that actually started before you even started using, maybe started with like a hyperactive extended amygdala, right? Like that hyperactive kind of, stress level that might have been, so you're not, in those situations, you don't necessarily really need like the genetic risk for developing a substance use disorder. But if you have some of those other risks, right now, all of a sudden, it's not that like, you're kind of feeling this unbelievable high that like, oh my God, right? It's that I just feel so much better. Like I actually feel like I could, yeah, I don't have to worry about those kind of negative emotions and those negative feelings kind of anymore.
Yeah.
Or, you could have been somebody who had a parent who also had a substance use disorder, and they don't have to like, that genetic risk it's not substance use disorder specific, at least kind of from what we understand to date. But you're right, your mom had a completely different reaction. So, so there's something about your body and your brain that responded very differently to that. Yeah. And it was much, then you kind of can imagine that with that feeling, especially as a 16-year-old, right? Like, oh yeah, I'm going to want to kind of keep doing this. Right.
Exactly. Yep. Exactly.
Yeah.
I felt like I could do life. And that's not what I thought was supposed to happen. But yeah, and I think thinking back to when I was a child, I did have ADHD and severe ADHD at that, and had several other diagnoses. So I did have I was hyperactive in many different ways, from my actual life probably down to my neurotransmitters. So
Yeah. Yeah. So, so you also mentioned that, kind of it took some time, right? That like that it didn't kind of happen overnight. It, and it wasn't something that you really were necessarily kind of consciously aware that like, oh, something is, maybe you thought that something was changing. But that neuroadaptation that you mentioned really does happen over time. It can take some time, right? And during that period, that basal ganglia, all of those dopamine receptors and the amount of dopamine that is released actually with each use, we know that that goes down. That's the body's way of trying to kind of get back to some of that homeostasis, that balance. And then the intensity of the reward and the responsiveness of the basal ganglia to that dopamine also goes down. And so, you're kind of describing this scenario of how this all kind of evolves, even without kind of a whole lot of your, totally understanding that this is these are these brain changes that that are kind of happening there. And so now you've, you're kind of describing this place where, the stress system probably becomes just really the most active, right? And when you're not then using. So when you then, were not able to get those prescription opioids, tell us, can you talk a little bit more about, kind of what was happening at the time, and then also like how you were feeling?
yeah, I mean, I remember, so I was a sophomore, so I would have been, I think, 19 or 20 when I first experienced my first set of opioid withdrawals, that I realized there was something seriously wrong. And because I remembered I had been taking, I had all been alternating between oxycodone and hydrocodone for close to a month straight, and averaging between 30 and 60 milligrams per day, which is a pretty high dose for someone who started as opioid naive. And it
right, keep going up, and you were like continuing to kind of, that tolerance was developing. Yeah. Sorry.
exactly. And yeah, no, and that's exactly true. I remember each day I would take the same dose as before, and I was like, well, this isn't working as well. I'm not feeling that same energy that I had. And then before I knew it, I was taking twice and three times the amount that I'd started. And then finally, when I had to stop and I ran out, I woke up, and you had talked about the flu, and like I remember thinking I was sick. I was like, I was coming down with something. But it was combined with, crippling depression and anxiety. And, you know, I felt like I could just crawl all over the walls because I didn't know what to do with myself. No appetite, nausea, chills, sweats, the whole gamut. And it took me, you know, I'd say about a day to realize, like, okay, this isn't a normal illness that I'm dealing with here. I'm not sick in the typical sense. I'm getting sick in another way. And then, you know, and that was, I don't know if it wasn't pre-Google, but it was pre pull out your phone and search Google to figure out what was going on. So it took me a little bit longer and a little bit more research to figure out exactly what was happening to me. But it you know, it's debilitating, and your mind and your body are screaming at you to fix the problem. And the only way you know how to fix the problem is by using more substances, because that's what caused the problem in the first place. And you know, the sense and logic and human ability to make logical decisions that keep you safe and healthy, those in many ways do go out the window, or at least they did for me, because, you know, you're feeling so ill, and you know, like I said, your mind and body are screaming at you to do something about that.
Yeah. And I think the other piece that you're kind of really describing are those other neuroadaptations that happen in the prefrontal cortex, right? That lead to kind of that increased compulsive, just like that, just attention, and, you know, even some of the changes in the importance that are paid to the people, places, and things that kind of are associated with the use of substance, and even just with the substance use themselves, right? So people can sometimes talk about smells that remind them, and kind of even can generate some of those withdrawal symptoms, even when they're not using. You know, walking down, seeing a street corner or a friend, or, you know, picking up kind of something. So those triggers really then are part of also some of the neuroadaptation and the brain changes that happen. And it kind of overpowers the control function that you're talking about. Like, it's just this kind of constant voice, you know, in your head, you know, as well as kind of all the physical pieces of in your body that are saying, you have to fix this, you have to fix this, and this is the way to do it. Yeah. So, you know, what did you, I know you kind of talked about how, like, you know, this was such you realized that the illness that you were going through was something more than just kind of, you know, the flu or a typical illness. But I'm also kind of wondering, as this whole process was happening, like, what were you noticing about what was changing or becoming more or less important in your life?
Yeah, everything that I thought was important became unimportant, and was replaced with finding and using more substance and more opioids. And I, you know, like many other people, you know, I progressed from oral opioids to intranasally or snorting them to IV, and IV heroin use and fentanyl use. And you know, I'm very lucky to be alive in many ways, because my recovery journey began in 2015, which is when we started seeing a lot of the fentanyl analogs in the substance supply. And so I do want to acknowledge, you know, the role that harm reduction and overdose prevention and primary prevention and the entire continuum of care plays, you know, around the clinical treatment system. You know, the continuum of care is an amazing thing when we have different parts of the system truly work together in conjunction with each other. So I went off on a little tangent there.
No, but I think that is so important, and so important to just know that, you know, this is a continuum, that really being able to have people you know, stay alive and get the services and that they need when they have the substance use disorder, and that there is a lot of prevention that absolutely can happen, and that also is really important. Well, I want to just kind of thank you, David, so much for really illustrating, you know, for us just now what was summarized on that slide. And just, and on this slide, and just really, you've made those processes come alive. And I also just am so grateful to have you as a colleague, as a friend, and for you to be in the world. So just really, really, really thank you. Can't thank you enough, for your input, your telling us your story, sharing your story. This is really incredibly valuable. So really appreciate it.
Grateful for you too, Dr. Wilson. Thanks for having me.
Yeah. And, I think what David really summarizes and talks about and illustrates on this slide, as I was mentioning, is that, we're all born with these neurotransmitter systems. They help regulate our key bodily functions and processes, but that too much of those substances with addictive potential can overstimulate the reward center in ways that nobody really intends, nobody understands, and that there may be kind of predisposing risk factors that people have that then lend itself to those brain changes also really happening in people who then develop the addiction, compared to people who may be taking an oxycodone and, like David's mom, doesn't have kind of that same type of response. And so then with those repeated exposures, really the brain adapts, right? So that those long-term changes can happen to the receptors, the cells, the neurocircuits in the brain, and that those changes then are manifested in that hyperactive stress system, a reward deficit, really, that we can control system, and deep-rooted shifts in what drives focus and motivation that all contribute to continued substance use. But I don't want to leave the story there, because as David also so unbelievably fabulously illustrates, and how there's so many people at SAMHSA that, and across the country, millions of people in recovery, that there is hope, because treatment and recovery supports can really help stabilize those brain circuits, strengthen the weakened connections between them, and move their functioning back towards balance. So that's at the cellular level. At the person level, I think, really, David, getting back to who you were, right? And even kind of maybe, I don't know if you want to say anything about what your life is kind of like at this moment.
Yeah, I mean, here I am speaking with you. I mean, that's self-explanatory. I never could have in a million years. And sometimes I forget to be grateful for for where I'm at. It's easy to get stressed, and when you want to say regular life, or however you want to call it. But going from in and out of the prison system to working for the government is such an honor and a pleasure. And like I said, I'm sure there's a lot of people on this webinar, which is so amazing to see. And I'm willing to bet all the money in my bank account that a good chunk of the folks on here have lost someone they love to overdose. And so I also want to take a moment to recognize that we have a lot of work to do. If not for the fact that we're going to save lives for those people that we've already lost, because I personally have lost friends and loved ones. I'm still losing friends and loved ones, and so we have to find a way to change the system. And I feel like we're starting to make some progress there. And so I'm just grateful to be part of it.
Yeah, great. Well, thank you. We're really grateful to have you as part of kind of that solution, because I think the other thing that we, also sometimes forget is that kind of treatment, that recovery process, that can take time. Right. And kind of recognizing that underlying differences in brain circuits of people with substance use disorder or addiction that can also create recurrence risk, but that we can minimize and really help, people avoid those recurrences, or at least if and when they happen, that we're there to be able to provide those supports and provide that care to really help save people's lives and kind of get them back on their feet. And so this is some of what we've been talking about all along today, is some of what kind of underlies the rationales to why we really are thinking about addiction as a chronic disease. And that's a concept that has been endorsed by scientific agencies, health organizations, professional associations, and research entities across the world, some of whom are listed, kind of here on this slide, and it includes SAMHSA, as well as many of our other partners across federal government. But it also means that right now, there is no current cure for addiction. But as I mentioned, really helping people with substance use disorders or addiction learn how to manage their disease, and so that they really then manage their recovery, and supporting them in doing that, that's really the focus. And so that stability also, we know, may not be achieved necessarily in a linear fashion. People can kind of have ups and downs, and that's okay. And helping with that often takes a treatment approach that combines medications when available with behavioral therapies. And we'll talk more about those at the January 30th webinar as well. I think this model also really recognizes that disease severity can change over time with periods of remission, recovery, as I mentioned, possibly even mixed in with periods of symptom recurrence. And, some of the analogies that are made is that this is what happens with diabetes, or hypertension, or major depression, and many other chronic conditions. And so it's not really as foreign as we sometimes kind of think it is. And I also wanted to point out that for Americans who may be in a situation where they find themselves either interested in or needing treatment, that SAMHSA has a treatment locator at findtreatment.gov that could be a place to start. This is a confidential, anonymous resource that really allows people to kind of identify what also they are interested in and looking for. And there are thousands of potential treatment services that can be identified through this findtreatment.gov. For those who are interested in more information and resources, things to read on the treatment of substance use disorders, SAMHSA's Evidence-Based Resource Center offers a lot of different materials for a range of audiences. So this is from family members and the public, healthcare practitioners in particular, as well as, people with a substance use disorder also may be looking for more information. David, as you mentioned, kind of pre-Google, there wasn't a whole lot. Now there's a ton, but really having access to factual evidence-based information. One of the sources that you can go to is SAMHSA's EBPRC. And finally, we don't at SAMHSA, and we can't tackle SUDs alone. I think, David, you really said it nicely, that this is given the size, the scope, and the breadth of the impacts of substance use disorders, this really takes a collective, coordinated effort to address them, not just across different health agencies within the federal government, but also with other agencies, some of whom are listed here on the right-hand side of the slide, whose functions and areas are ones that often intersect with people with substance use disorders and their families in different states, jurisdictions, and communities. And it really is this collective, coordinated effort that is happening at the federal level that also needs to be mirrored at the state and the local level. To really make a significant impact on the health and well-being of people with substance use disorders, their families, and their communities. And so I think our ask of everyone is to be a part of that solution, to be a part of reducing the impact of substance use disorders by really embracing this as the health condition that it is. And I want to just thank everyone for being here today. And I hope that the information that we provided has really helped reinforce that this is a health condition. This is not a moral failure. It is not a lack of willpower. It's not a disease of morality. This is really a health condition that we can treat and prevent, and that people can and do recover from. So thank you so much to all of you. We are excited about really this SUD treatment month to highlight the importance of that part of the continuum. But David, as you mentioned, this is really prevention, harm reduction, treatment, and recovery. It all needs to kind of go together. So thank you all again. And we hope to see you January 30th for the next part. And check out the SAMHSA's SUD treatment month website for more information, virtual background, social messaging, and our blogs that they're going to be coming out this month as well. So we really appreciate you all. Thanks.